Good morning, USRNs. Today we will talk about hematology. We will discuss about blood stem cell, aplastic anemia, erythropoiesis, polycythemia vera, iron deficiency anemia or IDA, pernicious anemia, and sickle cell anemia. The first thing that we will talk about is the blood stem cell. Let's talk about bone marrow. Bone marrow is the source of blood formation. Blood formation is known to be hematopoiesis. Inside the bone marrow, we have two stem cells, the lymphoid stem cell and the myeloid stem cell. The lymphoid stem cell contains T helper cells, natural killer cells, and macrophage. T helper cells supports the natural killer cells. It's also for immunity and CD4. The natural killer cells, also known as blind killers, if we experience problems to our natural killer cells, it will lead to an autoimmune disorder. The macrophage is the debris cleaner. If we encounter problem with our macrophage, we may experience tuberculosis or Koch's disease. On the other hand, we have myeloid stem cell that contains RBC, white blood cells, and platelets. The normal RBC is 4.5 million to 6 million. Compare it with the USRN salary in the United States. If there is an increase with RBC, the problem will lead to polycythemia vera. On the other hand, if the RBC decreases, it will lead to a problem called anemia. White blood cells, on the other hand, fights infection. The normal white blood cell count is 5,000 to 11,000. Compare it with the Philippine nurse's salary, which ranges around that amount. The third one is the platelets. The platelets is used for our clotting factor. If we experience problem with platelets, we may experience bleeding. The normal platelet count is 150,000 to 450,000. Compare it with a nurse that works in the Middle East. So when cancer attacks both stem cells, which is the lymphoid and myeloid stem cells, it decreases the function of all those cells and also decreases the function of myeloid stem cells. For lymphoid stem cell, the effect of the cancer, if it attacks, it may lead to superinfection. While if it attacks the myeloid stem cells, it decreases RBC, WBC, and platelets, which will lead to infection because of the decreased WBC, bleeding because of the decreased platelets, and anemia because of the decreased red blood cells. All of these will lead or may lead to aplastic anemia pancytopenia. Aplastic anemia pancytopenia. The next one that we will talk about is the aplastic anemia. Aplastic anemia always follows after stem cells are being attacked by the cancer cells. The risk factors of aplastic anemia are pesticides, chemotherapy treatment, autoimmune disorder, and this is also seen in IBAS. The treatment for aplastic anemia, because this is an autoimmune disorder, one of its risk factors would be corticosteroids. It could also be treated via chemotherapy or radiation, and you need to instruct the patient to avoid in crowded places because there would be a risk of infection. The immune system of the patient would be very low, So if they encounter a lot of people in a crowd, they would be at risk for other infection that they could get from other people. The characteristic of diet for aplastic anemia is low microbial, meaning they need to avoid fresh foods and avoid uncooked meat. Now we will talk about erythropoiesis. Erythropoiesis is the process of RBC production. Remember the normal values, shape and size. The normal values of RBC is 4.5 to 6 million. If there would be an increased number of RBC, it will lead to polycythemia vera. If there is a decreased value of RBC, it will cause anemia. The shape of an RBC, normal shape, is round, biconcave, and flexible. If there is a problem with the shape, it will lead to sickle cell anemia. The normal size of RBC is 3 to 5 UM. If there is an increase with the size, it will lead to pernicious anemia or megaloblastic anemia or macrocytic anemia. But if the size is decreased, it will lead to a condition called iron deficiency anemia. There is a decrease of oxygen due to RBC death. The normal RBC lifespan is 120 days. That's going to be your stimulus. So this is how RBC is being created. First, there is a stimulus, which is the decrease O2 due to RBC death, which alerts the brain. And then the brain will signal the kidneys. And then the kidneys will produce EPO or erythropoietin. And the erythropoietin will tap the bone marrow and will say, "Hey, bone marrow, can you produce immature RBC, please?" And then the bone marrow will produce matured RBC production. RBC can also be produced from liver, which through iron, especially from the parietal cells of the stomach. This also signals the bone marrow to produce immature RBC. Now we know how an RBC is being produced. We will talk about the diseases that has something to do with it. The first one is polycythemia vera. In polycythemia vera, there is a problem in respiration, which decreases the oxygen supply. Now, this is a stimulus that alerts the brain, and the brain signals the kidneys, and the kidneys will produce EPO. The EPO will tap the bone marrow, and the bone marrow will produce immature RBC. Then there will be an increased production of immature RBC. Now, since the bone marrow produces a lot of immature RBC, there would be a possibility that the patient's blood would become thick. See, for example, in COVID cases, the number one cause of death in COVID cases, as we hear it from the news or on TV, is that it has a respiratory attack. The management of this would be polycythemia. Treatment of the cause, which is polycythemia. We need to initiate phlebotomy, which is a therapeutic treatment for polycythemia vera. Instruct the patient to avoid hot spicy food, iron-rich food like liver, green leafy vegetables, dark dried fruits, red meat, raisins, dates, prunes, and many more. The following are the nursing management if patient is having polycythemia vera. The patient will experience pruritus. So if the patient is having some pruritus, we can offer cold shower to the patient, or during your NCLEX exam, the option to choose would be lower down the shower temperature. For those patients who will be at risk for deep vein thrombosis or DVT, you need to elevate the legs of the patient, ambulate the patient. For those patients with positive deep vein thrombosis or DVT, do not do ambulation, and there should be no bathroom privileges, and we can also offer blood thinners. Now, this is an autoimmune disease, so we can offer corticosteroids. The crisis for polycythemia vera is hypertensive crisis. This is an emergency. The two drugs that we can offer for people experiencing hypertensive crisis are hydralazine and sodium nitroprusside. Hydralazine and sodium nitroprusside. You should offer fluids to the patient. And the problem of polycythemia vera is coming mainly from increased RBC production. If there is an increase in RBC production, it will also increase the WBC and the basophils. If there is an increase in the basophils, it will lead to increase in histamine production, and too much histamine in the body will lead to pruritus. And again, for pruritus, we need to offer cold shower to the patient or lower down the shower temperature. It will also lead to an increase in blood pressure, which is the hypertensive crisis. And again, for hypertensive crisis, we need to offer hydralazine and sodium nitroprusside. It will also lead to vasodilation in upper extremities that leads to redness of the face or a ruddy red complexion. It will also increase the chance of blood stasis that leads to clot formation to the brain, which leads to ischemic stroke, to the lungs, pulmonary embolism, to the lower extremities, which is the deep vein thrombosis. Again, for deep vein thrombosis, we have two segments. Those people who are at risk for DVT, you need to elevate their legs and ambulate. For those patients who has positive DVT, there should be no ambulation, no bathroom privileges, and offer blood thinners. Anemia is the opposite for polycythemia vera. The next problem that we will talk about is iron deficiency anemia. The iron storage and production and RBC level are being decreased. People who are at risk for IDA are children, females, and pregnant women. The oxygen and hemoglobin are also decreased, which causes activity intolerance. Noticeable signs for people having activity intolerance are frequent rest periods. You need to document the increased respiratory rate and heart rate, and also pallor. The hallmark signs of IDA are PAK, pica eating, angular sclerosis, which is the side lips cracking, and koilonychia, abnormal nail spooning. Again, the three hallmark signs of IDA are pica eating, angular chelosis, and koilonychia. So what happens in IDA? There is an increased iron storage in the body, And the diet should be changed, or diet should be advised, like organ meat, green leafy vegetable, dark dried fruits, lean red meat. Patients should also take ferrous sulfate. Encourage orange juice when taking it orally. Need to use straw for liquid. Client can also get through IM. You will need to administer it via Z-Track. The next topic that we will talk about is pernicious anemia. Pernicious anemia, remember that there is an increase of the size of an RBC. Normally it's just 3 to 5 UM. Now this is more than 5 UM. So the effect of it is that there is a decrease of vitamin B9 and vitamin B12. This is what we need for a mature RBC. So what happens in pernicious anemia? Since there is a decrease in vitamin B9 and vitamin B12, there will be an immature RBC production, because the body would notice that our body needs more production of RBC. Because of the decrease of vitamin B9 and B12, we need to produce a lot of RBC. So this creates a problem in blood circulation due to weak RBC, because ang pinuproduce ng katawan natin is immature RBC na. So there will be an increased size of the RBC that will lead to destruction of microvessels sa blood circulation natin. So kapag meron tayong destruction of microvessels, it will go to our blood flow. And sa blood circulation, meron ng decreased blood flow. So sa eyes, the patient would experience blurry vision. Sa tongue would be beefy red. Sa fingers or feet naman is paresthesia. The decreased blood flow will lead to regulation of nerve health from the decrease of vitamin B12 and vitamin B9. There will be a decreased function of nerve health, which will again lead to paresthesia. And in the long run, it will lead to mental retardation. Now, the test to determine pernicious anemia would be Schilling's test. Schilling's test is a 24-hour urine collection to verify traces of vitamin B12. Vitamin B12 is the missing intrinsic function of the stomach. The management for pernicious anemia would be vitamin 12, and that should be given for a lifetime. Now let's do some partial notes. For partial gastrectomy, we have two parts, the Billroth 1 and the Billroth 2. Billroth 1 is for gastroduodenostomy. Billroth 2 is for the gastrojejunostomy. It's in alphabetical order: gastroduodenostomy and gastrojejunostomy, Billroth 1 and Billroth 2 respectively. The final topic would be sickle cell anemia. Sickle cell anemia is considered to be a genetic problem, which is termed as autosomal recessive. In family, both parents are the carrier, and the victim would be the child. This is hereditary, and this is not curable. This is known to be a DNA and RNA problem that will lead to S trait formation, and this will end to abnormal RBC from a normal RBC. When this is happening, it will lead to a crescent moon shape. Again, crescent moon shaped. That will lead to cascaded sickling because of the abnormal RBC that anchors to the normal RBC. It will affect to hemolysis. Now, the level of oxygen will decrease, and hypoxia, anaerobic metabolism, lactic acid production. Lactic acid irritates the nerves. That will lead to general pain. Again, if there will be a decreased oxygen, it will cause hypoxia, anaerobic metabolism, lactic acid production, and the lactic acid production will irritate the nerves. That will lead to general pain. There will also be a high volume of dead RBC2 spleen or splenomegaly. There will also be a decrease in blood volume, which will lead to shock. The sickle cell crisis or severe hypoxia will lead to oxygen, or the nursing management for sickle cell crisis and severe hypoxia would be oxygenation and hydration. The management for vaso-occlusive crisis and severe pain would be hydration and morphine. You need to watch out for lower upper quadrant pain because that is where the spleen is located. You need to watch out for lower upper quadrant pain for splenic sequestration or rupture. That will lead to bleeding and shock. This is an emergency and must be reported to a healthcare provider. Thank you for listening.